So things have evolved in recent years, and we now have, of course, drugs like ibrutinib, which are very different from our traditional chemotherapy or chemoimmunotherapy regimens. And they allow the use of an oral therapy that's well tolerated and is very effective. So that's an important issue when you think about the fact that the majority of patients with CLL, when they're diagnosed, are 70. Most patients don't need treatment right away, so when they do need treatment, they're usually in their mid-70s. So tolerability of therapy is quite important. So we have drugs like ibrutinib, and I'm sure there will be more similar oral drugs that will eventually move to frontline. And then in comparison, we have our traditional chemoimmunotherapy. Those regimens, although they're fairly well tolerated, they're still harder than taking a pill. So they do have toxicities, infection, etc. And for people who have a lot of comorbidities, that's a significant issue. We also have antibody therapies, and so, for example, obinutuzumab with chlorambucil is also approved frontline. So that's a sort of kinder and gentler as well. Certainly a little more difficult than taking a pill, but it's probably not as effective, or certainly the durability of it isn't as long as the oral therapies. So on the one hand, you have a pill you can take, go about your business, hopefully have little impact on your daily life or quality of life. But right now, you do have to take those continuously. We haven't explored stopping therapy yet. And with our more traditional chemoimmunotherapy regimens or just immunotherapy, antibody therapy, they're given for a defined period of time, 6 months or so. So that's the trade-off. And then, of course, the other issue that always comes up is cost, financial impact.